Is postoperative residual paralysis a rare phenomenon or a common and clinical relevant situation? Addressing this question is our main topic during the next 60 minutes. And so, welcome to our live TV Trends in Perioperative Care. My name is Gerd Wirtz and I'm your guide through this roundtable meeting. But first of all, let me introduce our today's experts. Beginning with Professor Jennifer Hunter from the University of Liverpool, United Kingdom. She started her research on pharmacodynamics and pharmacokinetics of neuromuscular blocking drugs in the 1980s. She has been editor-in-chief of the British Journal of Anesthesia and chairman of the ESA Scientific Program Committee for several years. Next to me is Professor Claude Meistelmann. He is chair of the Department of Anesthesia and Critical Care at the Brabant University Hospital in Nancy, France. He is involved in research of neuromuscular agents and neuromuscular monitoring since 30 years, and he was in charge of writing the chapter about neuromuscular blocking agents in Miller's anesthesia textbook. And Professor Manfred Blobner. He is vice chair of the Department of Anesthesiology at the Technical University of Munich in Germany. And he is responsible for the perioperative management of this institution and does research on operation management. He is expert in clinical and preclinical research on muscle relaxants since 1989. So first of all, thank you all for coming and sharing your great experience with us. There is growing evidence that the use of NMBAs in routine surgery may be associated with significant adverse respiratory outcomes postoperatively if not managed properly, and thus leading to increased rates of morbidity and even mortality. So let's have a closer look today on the clinical impact of residual paralysis and how could a neuromuscular transmission technology help to minimize or eliminate that problem. Yeah, and you're all invited to take part in this discussion. So please don't hesitate to send us your anonymous questions by using the chat tab on your screen. And I will pass them to our speakers. And we have time after each presentation to address some of these questions. But we also will start a panel discussion with all our experts at the end of the lectures. And now we're ready for the first presentation. And I'm looking forward to the presentation of Professor Hunter. You will give us an overview of the state-of-the-art of residual paralysis and clinical impact.
Thank you, Mr. Chairman. Good afternoon. Our story today begins in Copenhagen in 1997, when V.B. Mogensen and his group first suggested that the use of muscle relaxants and residual block in the recovery room was related to the post-operative pulmonary complications we subsequently saw. Look at this data, and on the left-hand side you can see the train-of-4 ratio greater than 0.7 on the top line, less than 0.7 on the bottom line. And look at the pancuronium incidence of post-operative pulmonary complications, significantly greater at 16.9% in the patients who came into recovery with a train-of-4 ratio less than 0.7. In those who had a train-of-4 ratio greater than 0.7 after pancuronium, it was 5%. This was significantly different, but after the intermediate-acting neuromuscular blocking drugs, atracurium and vecuronium, there was no significant difference in the incidence of post-operative pulmonary complications, whether your train-of-4 ratio was less or more than 0.7 in the recovery area. And this original finding was the opening to a host of research studies which we're going to talk about over the next 20 years. The findings were substantiated by Nagoob and his colleagues in a meta-analysis in 2007, which again suggested that it was mainly long-acting neuromuscular blocking drugs that were responsible for this increased incidence of post-operative pulmonary complications. But a French study published in Anesthesiology in 2003, a prospective study that looked at the incidence of a train-of-4 ratio less than 0.9 in patients who had received atracurium, vecuronium or rocuronium, just one dose, but alas, no reversal. And they came into the recovery area and 45% of them had a train-of-4 ratio less than 0.9, which is frightening. Indeed, 2 hours later, 10% of them still had a train of 4 ratio less than 0.7, and nearly 40% of them still at less than 0.9. I stress after no reversal. Not surprisingly, the incidence of this problem was greater in patients who'd had shorter operations, repeated doses of muscle relaxant, or infusions of a muscle relaxant. But these were similar prospective findings to a retrospective study that Béliard and colleagues had also done in France in 2000. Alas, these findings still occur because this paper from Canada, many years later in 2015, suggested that of 300 or more patients who'd had rocuronium, only 70% of them had been reversed with neostigmine. And monitoring had only been of the subjective type, assessing the train of 4 count or looking at the twitch response in the hand. Disappointingly, still in 2015, 50% or more of these patients had residual block. That's just not good enough. Now remember, if you bring your patient into the recovery room with a train of 4 ratio greater than 0.9, they are likely to stay there for a shorter period. This work came from Harvard, from Eichermann's group, and these times are much longer than we might anticipate in Europe, but nevertheless, they are statistically significant. Patients who had a train of 4 ratio greater than 0.9 stayed for 240 minutes in recovery. Those with a train of 4 ratio less than 0.9 for over 320 minutes. That's statistically different. This was related to the age of the patients, undoubtedly, but it was not related to the relaxant used, although there was, somewhat disappointingly, a higher incidence of the train of 4 ratio less than 0.9 after vecuronium. And at that time, we sent a questionnaire out to anaesthetists both in Europe and in the United States, asking them about their current practice as far as neuromuscular monitoring was concerned. These figures were disappointing. Routine reversal was more common in the USA, but still in only a third of anaesthetists were using it. And in Europe, only 18% of anaesthetists were using reversal agents in 2010. 19% of Europeans, nearly a fifth, and 10% of Americans never used neuromuscular monitoring. And what was most disappointing of all in this study, that most of the anaesthetists believed that they had never seen residual block in the recovery room, despite the figures that I've just showed you. Work in 2015 from the States, from Murphy's group, another prospective study, suggested that post-operative pulmonary complications after muscle relaxant anesthesia were more common in the elderly. 58% of elderly patients in their institution were coming into the recovery room with residual block. 30% even of the younger patients had residual block there. All these patients had received rocuronium, and I'm afraid that hypoxemia, post-operative pulmonary complications, and length of hospital stay were all increased in the elderly patients. And certainly, all these respiratory complications post-operatively were more common in the groups that had had residual block in the recovery room. So this led all those interested in neuromuscular pharmacology to look in more depth at the incidence of post-operative pulmonary complications after muscle relaxant anesthesia. And here I have summarized 5 recent studies from the United States that have looked at the effect of using a muscle relaxant or not using one, reversing it or not reversing it, on the incidence of post-operative pulmonary complications. So look at the left-hand side, and the first 3 studies named in red are all from the one institution in Massachusetts. And the other 2, as I say, are also American. Now, in the patients who received no neuromuscular blocking drug peroperatively, the incidence of post-operative pulmonary complications was 5 per 10,000 patients in Bulker's study, 1.4% in Bronson's study, which was done in US veterans. But when these patients received a neuromuscular blocking drug, there was evidence that the incidence of postoperative pulmonary complications was higher. Look at the third line, McLean there, 6.7%, and Bronsett at the bottom, 5.7%. So we're talking about a similar incidence of postoperative pulmonary complications to Berg's original study. Now, importantly, and this is more recent research, when we look at the reversal column, the incidence of postoperative pulmonary complications varied according to the study. So look at McLean's study there, where reversal 4.1% was in fact higher than in the final column, where none of his patients were reversed, when it was only 2.7%. And this was concerning, but it was not substantiated by the other two studies by Bulker and Bronsett, which suggested that if you reverse the patient, then the incidence of postoperative pulmonary complications was less than if they received no reversal agent. That's the final column, the bottom two lines. What I hope this slide demonstrates is at this point in time, there is still confusing evidence about the relationship between postoperative pulmonary complications and the use of muscle relaxants and reversal agents. But most importantly, and this is very new information released only this week online on Anesthesia and Analgesia's website, a consensus statement has been released in the US to guide you in your perioperative use of neuromuscular monitoring. And these are the 5 main messages of my talk. Whenever a neuromuscular blocking drug is used, block must be monitored. Quantitative monitoring is necessary, which measures the train of 4 ratio. Ideally, the hand muscles should be used. We're going to talk about that a bit more. And all this implementation should be led by heads of anesthetic departments and national professional societies in anesthesia. Because inevitably, knowing our specialty, repeated reinforcement of these guidelines will be necessary in the future. Thank you very much, Mr. Chairman.
Thank you, Professor Hunter, for this update and for this impressing and also alarming figures you showed us. And you gave us very clear recommendations. And thinking about these recommendations, do you think that guidelines are needed to improve the adherence of these recommendations? I do. I think that guidelines are part of modern day medicine, that all new trainees and residents come to work by them regularly. And the more and more they are used, the more it is necessary for neuromuscular monitoring guidelines to be available. And the people that we've got to convert aren't the new trainees, not the residents in anesthesia. They're the staff grades and the consultant anaesthetists who've been working for years in the specialty and are less likely to change their practice now. But I am sure that that is what is necessary in the future. And I am sure, too, that it needs to be regularly reinforced. We have already a question from the audience outside. What do you think? Is post-operative residual paralysis easily detectable at first sight?
There is no way that you can be sure that you can detect it by sight alone. That is one of the messages that I've just tried to put over. We're going to talk about this a bit more now, but appropriate monitoring of neuromuscular block is essential to determine residual paralysis. No way can the eye or the finger be assured that they can detect it. Even experienced anaesthetists like V.B. Mogensen has demonstrated that when the train of 4 ratio is greater than 0.4, none of us can determine it accurately by sight or feel alone.
Thank you very much. And I think now we should focus on the rules which must be applied to avoid residual paralysis. And there we get an overview from you, Professor Meistelmann.
Thank you very much. Good afternoon, everybody. I have a very difficult task. I have to convince you that Professor Hunter is always right, as usual. So let's move to the first slide. So this slide summarizes a study published more than 20 years ago in Canada. So in the red box, you can see the patients who were monitored by a simple nerve stimulator. And in all the patients, an adequate level of neuromuscular block was obtained. On the other hand, as you can see, the upper curve, the patients were not monitored perioperatively, and we often forget to talk about monitoring during surgery, were poorly paralyzed. And in the early 2000, Arbus published a study and demonstrated very nicely that there were several factors which could increase morbidity and mortality in anesthesia, and among these factors, the lack of neuromuscular monitoring and the lack of use of reversal agents was a key issue. And this led to a very provocative but interesting editorial by Mark Warner in Anesthesiology, telling the people, okay, this is the common thinking. We don't use nerve stimulator, battery is always off, but just think about the risk if you don't rely on these nerve stimulators. And more recently, once more, Glenn Murphy's group in Chicago studied the rate of postoperative pulmonary complication in the PACU. So these complications were upper airway obstruction, respiratory distress, and hypoxemia. And they observed over a 1-year period 42 cases of critical respiratory events in the PACU. And they compared and they matched the data to a control group. And interestingly, there were no significant differences in preoperative or intraoperative parameters, such as the length of the procedure, the choice of the anesthetic agent, the age of the patient. The only significant factor was a lower train-of-fall ratio in the group of patients who experienced critical respiratory events in the PACU. As you can see, the average train-of-fall ratio in the control group was above 90%, whereas in the group of patients who experienced this respiratory complication, train-of-fall ratio was around 62%. And let's go back to Europe. Christophe Bayard and his group in France studied the factor which could explain the risk of residual paralysis in the PACU. And interestingly, you can look at the odds ratio. If you don't monitor your patient perioperatively and when arriving in the PACU, the odds ratio is around 3. It means you have 3 times more residual paralysis in the PACU. And if you don't reverse the patients, you increase the risk of residual paralysis in the PACU. And on this slide, they summarize more than 10 years of survey of the patients arriving in the PACU. In 95, and Professor Hunter already referred to these results, the use of neuromuscular monitoring and the use of reversal was seldom in this hospital. And as you can see, around 60% of the patients when arriving in the PACU had a train-of-fall ratio less than 90%. In other words, were at risk of respiratory complication when arriving in the PACU. And over a 10-year period, by a concomitant use of nerve stimulator and reversal agents when needed, you can see this is the gray boxes with this huge increase in the use of reversal agents and neuromuscular monitoring, they observed a very significant decrease in the rate of patients experiencing residual paralysis when arriving in the PACU. However, there have been some studies already discussed by Professor Hunter, and this is once more one study from Matthias Eichermann group in Boston. And interestingly, they compared 2 groups of patients. What is called the appropriate group is the group of patients who received neostigmine and after information provided by the neuromuscular monitoring. What is called inappropriate is unguided use of neostigmine or higher dose of neostigmine above the recommended doses. And as you can observe, the red box, one more, atelectasis, you have 50% more atelectasis when neostigmine is given in an appropriate method, for example, without any use of neuromuscular monitoring. So to summarize, and what is very important at that moment is, as pointed by Professor Hunter, a systematic use of neuromuscular monitoring each time you give an NMBA. Of course, you will adapt the dose and the choice of the NMBA depending on the type of surgery, the type of patients. We can discuss that for hours and hours, but the key issue, whatever neuromuscular blocking agents you will give, please monitor your patients with objective monitoring. Clinical signs are misleading. And these are the guidelines which were published concerning the use of neostigmine a few years ago, and that's straightforward. Just monitor your patients and look at the number of response at the trainer for. And if you give neostigmine at the correct dose, 40 to 50 mics per kilo, following the information provided by neuromuscular monitoring, you will avoid the increase of complication due to an inadequate use. And even more recently, Sugammadex has been introduced in clinical practice. And this paper came from Japan. And in Japan, when Sugammadex was introduced at that time, they were not using in clinical practice neuromuscular monitoring. And as you can see, this is a red box, even when using Sugammadex, around 5% of the patients arriving in the PACU has a trainer for ratio below 90%. So this is a clear demonstration on the need of neuromuscular monitoring, whatever reversal agent is used. Just to summarize this presentation, each time you give an NMBA, please monitor your patients. Remember that subjective clinical tests are not sensitive enough and can even be misleading. The only way to indicate complete recovery from neuromuscular block is a trainer for ratio above 90%, and by simultaneous use of neuromuscular block monitoring and reversal agent, then you will prevent easily residual paralysis. Thank you very much.
Thank you, Professor Meiselmann, for giving us a bit of advice in this critical field. And by the way, do you have any suggestions about using the most suitable NMBA in relation to the patient and the surgery at all?
Well, two comments. First, it depends of your experience and it depends of the knowledge of a drug. The problem, in my opinion, is not the choice of the intermediate duration of action NMBA. The real problem, I don't care too much about the choice of the NMBA, but I care about the routine use of neuromuscular block monitoring. And I think this is what prevents postoperative complications.
Agree, the other
Oh,
two?
indeed.
Yeah?
Perhaps I don't agree fully about, I don't mind which relaxant, because I do mind to a large extent which relaxant, depending on the patient group. But I fully agree with Claude about the need for monitoring being the prime lesson of this lecture.
Professor
I
Bloch?
completely agree. First of all, we have to monitor our patients. Then we know what we do. Otherwise, it's like flying blind. No, monitoring is mandatory, and if it is done, then you can consider which drug, which reversal, and so on.
And I think a very special field is anesthesia of children. And we have a question here from the audience. Is there any specific recommendation concerning the NM paralysis in children?
No, there are no specific recommendations. You can routinely monitor the children, even the infants of the neonates. The only suggestion I could give, if when you monitor infants or neonates, that's very simple, you have to use smaller electrodes, pediatric EKG electrodes, and that's it. Now we have some very accurate nerve stimulator. It was an issue 20 years ago, but not more.
We did it in very small infants, down to 1,000 grams, and it worked very well. So there is no excuse. if you're not using that in the smallest ones.
Okay, thank you. And we have another question. Sugammadex appears to be relatively less efficient with vecuronium, rocuronium, and not at all with benzoylquinolines and atracurium and derivates. And what about calabadione, which might appear in animals as the new Sugammadex that works with all muscle relaxants? And the one who asked, he says, I saw no papers in human. Do you saw papers in human?
No, there is no paper in humans so far.
Not for calabadione.
No, there is only data in animals. We participated in one of the studies, and it's really working comparable to Sugammadex in rocuronium, but there is also a good effect in cis-atracurium, but there are no studies in humans so far.
And are there studies in sight? What do you think? Is it?
I expect.
Yeah.
I think that question is confusing. We must make clear that Sugammadex only antagonizes the aminosteroidal agents, vecuronium and rocuronium. It does not antagonize the benzyl isoquinoliniums. So if you were dreaming of an ideal relaxant reversal agent, then you would want one which antagonized all relaxants, would you not? And that is the way the calabadians have been developed. Now, the first one actually was more efficacious against the aminosteroids, but it did reverse the benzyl quinolinium cis-atracurium, which of course Sugammadex didn't do. But the second calabadian that was investigated was even more efficacious in animals at reversing rocuronium than Sugammadex was. And it reversed cis-atracurium as rapidly as it reversed rocuronium. But it is small animal work. It's rodents.
Definitely, it's animal work, and but I also expect work in humans in the near future. But so far it's speculation. So,
but they are very interesting.
Promising stimulation, but
these drugs act in the same way as Sugammadex. They're not the same chemicals, but they are encapsulating agents.
Yeah, like a wrap. It's like a wrap. It goes around the drug. So. Rocuronium is a smaller molecule than cis-atracurium, so if you have a hole, like it is Sugammadex, it doesn't fit to both. This is a wrap, so it can wrap around the drug irrespectively the size of the molecule. So it's a new but comparable idea, but it's still under investigation, and as mentioned, we have to wait for human results.
Thank you very much for this clarification. We learned from Professor Meiselman that monitoring is mandatory, and now we are keen to hear much more about the added value and the technological differences of neuromuscular monitoring technologies. And this is your part, Professor Blobner.
Thank you very much for introducing me, and welcome everybody. Yeah, Professors Hunter and Meiselman taught us that residual blocks are critical events. They have to be identified, they have to be treated, and finally, they have to be excluded before the patient is extubated. But as always, every aim, however, it is only be achieved when the first step is not lacking sufficient quality. Therefore, I will set some spotlights on the specific properties of neuromuscular monitoring technology. In particular, I will speak about why is quantitative neuromuscular monitoring necessary and why is EMG the preferred technology. Let me come back to Vivi Morgenson. Jürgen has been cited so much this evening.
Not surprisingly.
Yeah, not surprisingly. He put his criticism to tactile neuromuscular monitoring in one sentence. And he says, tactile neuromuscular monitoring is imprecise. And he gave the explanation in the same sentence because it's user dependent. And Jenny told us the explanation why it is. One of the most important results was that even experienced anesthesiologists are not able to touch fading when the TOF ratio has been recovered to values of about 60%. And less experienced ones are not able to detect fading in at a TOF ratio of 40%. So with other words, it's again user-dependent, and even the best can't touch a residual block. Glenn Murphy compared the use of peripheral nerve stimulators with a quantitative device with acceleromyography in a very interesting, and I think it's a pivotal study. Here are the results of the neuromuscular monitoring that has been done in the PACU in two groups. In one group, the conventional TOF group has been using peripheral nerve stimulators. And in the other group, anesthetists were allowed to use acceleromyography. And they were asked to do the best job. That means they all targeted to have the patients recovered completely when they overgive the patients to the staff of the PACU. And these are the results you can see. The PNS group, the conventional group, did not reach that target. They missed because many patients had a residual block. About 51% had a block, a residual block or a TOF ratio below 0.9. And the result for the patients was that the PNS patients had episodes of deoxygenation during the transport, but also in the PACU. And even more important, they required airway maneuvers in about 11% during the transport, but still when arriving the PACU. So to address why electromyography is a preferred technique, I will recall some knowledge from physiology. Muscle relaxants are acting at the neuromuscular junction. When given in an effective dose, they inhibit opening the end plate channels, and consequently, they suppress the compound muscle potential. Therefore, the first signal that allows us to measure the effect of neuromuscular blocking agents, of muscle relaxants, is the depolarization of the muscle membrane. And this can be done by electromyography. Stimulation of the ulnar nerve, one control electrode following next, and then measuring the compound action potential either on the hypothenar, on the right side of the slide, or at the adductor pollicis muscle, is a preferred technique to do electromyography in patients. All further techniques, irrespectively, if you do it tactile or acceleromyography or whatever, measure a mechanic effect, and accordingly, everything that may disturb the measurement technique can lead to interferences. And interferences can be a new position of the arm, changes in preload, which is not controlled, especially if you're using a device like this acceleromyograph. Touching the thumb, touching the hand, touching the arm, these all can affect the measurement. So it is not really surprising that acceleromyography does disappoint when the effects, when the measurements are compared with other techniques like mechanomyography or especially with electromyography. This is a very, again, pivotal study performed by Cabron and colleagues. And they compared the values of mechanomyography and electromyography at specific levels of acceleromyographic TOF ratios. And they found that AMG always overestimates TOF compared to the mechanomyographic measurements. When the TOF value with AMG is 0.9, only 40% of the patient really had a TOF of 0.9. 60% had lower levels. Accordingly, there was a recommendation that in patients that are monitored with AMG, we should target on a TOF ratio of 1.0 in order to have a complete recovery of 0.9 controlled with mechanomyography. And the same can be found when you compare acceleromyography with electromyography. This is also very important work done by Liang and colleagues who measured the effects on the same thumb muscle. That means they did acceleromyography as well as electromyography on the same muscle. And they found also, comparable to Capron, that there is a bias. This Altman plot clearly shows that the technique of acceleromyography overestimates the recovery by 0.2 points on average, but in some cases there was an overestimation of more than 0.4. That means a patient that shows 0.9 can also have 0.5, which is definitely a residual block. And it's very important to discuss about that bias, but it's also important to discuss about precision of measurement. This is important because extubation is suggested at TOF ratio over 0.9. And the normal recovery curve is very flat in that area. That means imprecise measurements result in uncertainty for the decision. Especially if we are discussing about risk of recurrization, this is an important issue. Here is a case demonstrated by Duval-Destin, published 2010. Recurrization, which is when the TOF ratio comes up to a level and goes down again, most frequently appear if the reversal agent is underdosed, which was the case in that patient. But here we have precise measurement in order to detect it. I show you two traces as an example what happened with the blue acceleromyography in comparison to the red electromyography. And you can see these fluctuations, especially in the upper graph. And what is the real TOF? Is it in the first moment 90% or is it 60%? You never know because it's fluctuating too much. And so therefore it's no wonder that many anesthetists still doubt neuromuscular monitoring when they are seeing such curves. I normally recommend in such cases use electromyography, then you have these clear curves and you can do clear decision making, and then quality allows us clinical decisions based on neuromuscular monitoring. Let me summarize. AMG overestimates TOF ratio. It's the lower preferred technology that to measure neuromuscular function. Even calibration doesn't improve the quality because there is a principle behind of this measurement technique. EMG does not overestimate TOF ratio. TOF ratio recovers never to values over 1.0. So TOF over 0.9 measured with EMG indicates advanced recovery and allows extubation of the patient. Thank you very much.
Thank you very much. I think you gave us a very clear picture of the differences between neuromuscular monitoring and gave us a good advice how to go on with it. What do you think? Can a good use of EMG technology totally replace the antagonist?
No. It's important that the patient has completely recovered. And in many cases, it's not possible to achieve that target without reversal agents. In principle, yes. If you're doing neuromuscular monitoring and you have enough time, let me say in some cases 2 or 3 hours, to wait until the patient has a spontaneous recovery, it's from a medical point of view acceptable. But it's not acceptable in terms of operation management. So every OR manager will be very disappointed if you need 2 hours or more in order to have a completely recovered patient. But in principle, the target is to avoid residual block, however you do it.
You've got to remember that rocuronium is a very long-acting drug. It has a terminal half-life of 90 minutes in patients with renal failure, 70 minutes in healthy patients. It takes 5 elimination half-lives for your plasma level to go down to 3% of what you started with at peak. If you do not reverse that patient, then it's a very long-acting drug, and it has impracticalities, as Professor Blobner says.
The issue is the variability. We had done a study in abdominal surgery patient 10, 15 years ago, and there we found that the median time between the last dose of a neuromuscular blocking agent and complete spontaneous recovery is about 55 minutes. But there are some cases with 3 or 4 hours. So the variability is too high. So you can't give
Especially if they've had a potent inhalation agent as well.
I think Professor Meiselman, you would
I
like
would
to
be a
add
little
something.
bit more cautious about that. You know, the real issue, because there is a very large inter-individual variability, whatever the NMBA given to the patients. Really, I stick on that. Monitor the patients and okay, a single bolus dose is fine. Usually, you get in trouble when you are using repeated doses and when you don't monitor the patient, because then you are completely blind. And as I show you on the first slide, when you base your readministration on clinical signs which are fully misleading, you never know where you are. Are you overdosing? Are you underdosing the patients? You never know. So that's really the key issue perioperative, because many people consider that monitoring is interesting to detect residual paralysis, and that's where they get wrong. Monitoring is very useful perioperatively to know when giving a repeated dose of NMBA, or if you have a resistant patient, because some of the patients are very sensitive, some of the patients are rather resistant to the effect of any NMBA. And this is the other interest of monitoring, to know where giving readministrations.
So thank you very much. We jumped already in our panel discussion round, and we have already some questions, but I would like to encourage the audience all over the world. Please send us your questions, and all the referents will be happy to answer them. But first of all, I have 3 or 4 questions. Professor Blobner, what alternative stimulation sites can be used when the ulnar nerve is not accessible?
Yeah, in principle, you can use many sites. The most interesting alternatives are the eye muscles, because stimulating the fascial nerve, you can measure around the eye mimic muscles, which many of them are very good related to abdominal muscles, and therefore you may better correlate the paralysis for surgical issues, but you're still in a safe conditions when the neuromuscular block is completely recovered. That's the most suggested alternative. Yeah.
I have something to say which is very important. Professor Blobner is right. You can stimulate the fascial nerves and monitor the corrugator supercilii. However, this is only for perioperative monitoring. If you want to detect residual paralysis, as stated by Professor Blobner, these muscles are resistant when compared with upper airway muscles or peripheral muscles to the effects of an NMBA. So you can use the fascial nerve to monitor perioperatively the neuromuscular block, but not for detection of residual paralysis or reversal from neuromuscular block. This must be highlighted.
Yes, because it's difficult to measure the train of 4 ratio in some of the facial muscles accurately. That's the main thing. So that's where it comes to residual.
In such cases, we normally recommend to measure the eye muscles during surgery, but at the end of surgery, when the surgeons go away, then you are able to go to the arms. And the arm muscles or the hand muscles are the reference. And to decide for extubation, we, for example, have created an algorithm that is based on the last 10 minutes in order to definitively avoid residual block. And these 10 minutes are also always available. So yes, it's a good option to control muscle function during surgery, but decision at the end, yes, should be done on their own.
Should trainer 4 be checked prior to administration of NMBDs? And are we able to achieve a more optimal relaxation if we do it? According to Professor Lars Eriksson at Karolinska, who has done a lot of studies on neuromuscular blocking, he said you should only, you should only do it if you are performing a study about NMT. What is your opinion to that statement from the outside?
Yeah, so it's clear that the surgical conditions can better measured or monitored by the surgeon himself or herself. So that means if the question is the block deep enough, for example, then we should accept the advice of the surgeons. But at the end, I think it's necessary to, sometimes it may be necessary to avoid movement of the patients. And then we have to monitor intraoperatively, and that's necessary also for clinical routine. And even more important, if you have, when I have a precise measurement, then you have to calibrate the monitor before giving the first dose. And why not measuring during surgery? And why should we stop doing that? I think Lars Lars Eriksson didn't mean it exactly.
Other opinions to that?
I felt that he was saying that it was important with a research study to have that control value. After all, the Trainer 4 was described as a clinical monitoring tool that did not need a control value. That was the whole reason for developing the Trainer 4, not for research purposes, but as a clinical monitoring tool. But if you're doing any research studies, then it is important to have that control value measured accurately. But in addition, some modern developments in neuromuscular monitoring technology are allowing us to do a good control reading of the Trainer 4 with, before the relaxant is given, without too much delay, because the problem with mechanical myography and electromyography as research tools were that in the old days you had to use several minutes getting your control value stabilized before you gave your relaxant. Now, some of the clinical monitoring equipment has improved now, such that that can be obtained more quickly.
You raise the problem of calibration before giving the neuromuscular blocking agents. It was true 20 years ago, but our nerve stimulator, the nerve stimulator part of the neuromuscular monitor, they become more and more reliable. And what was almost mandatory 20 years ago is not mandatory anymore, because we have some very accurate nerve stimulator, and we saw some huge improvements when compared with what was observed 20 years ago.
How reliable is NMT on the awake patient?
It is, there is no quantification. It never has been investigated before. So the only things that have been done from Lars Eriksson's group, they compared neuromuscular monitoring in awake volunteers. So finally, we should not focus on neuromuscular monitoring in the PACU. We should focus on neuromuscular monitoring in the anesthetized patient. And when we can exclude a residual block, then the patient is allowed to awake. Then the discussion about the quality of neuromuscular monitoring in awake patients is not necessary. Now, many of the research that has been done uses these devices in awake patients, but it's never been controlled by something different.
Yes. I am always amazed at that original Berg paper from Denmark, how well they got Trainer 4 ratio values in conscious patients. Because I've had it placed on me in the conscious state, and I don't find it at all pleasant to have it done repeatedly. but people vary hugely in the way they tolerate that. There is quite a lot of difference around healthy people in how well they'll tolerate it. But no, I agree entirely with Manfred. You measure it before they wake up.
But let's be a little bit even more provocative. Do we need monitoring in the PACU, or do we need monitoring in VOR? In my opinion, when you bring your patient to the PACU, you want to have a patient with free ventilation. So in other words, what we try to do in every case is to monitor and reverse, if needed, your patients in VOR before transferring him to the PACU. I think it's a safe way. I know in some PACU they bring the patients under intubation and controlled ventilation.
I don't
but
mind that.
if you have a large turnover, and I think that's your job, take off for anesthetist, it's induction of anesthesia. But do you know any pilot who does not want to land safely? So I would say we should have our patients fully recovering in VOR rather in the PACU. If you are doing a good job, you only need your nerve stimulator and your monitoring in VOR.
Yeah.
Thank you very much.
The other point I'd like to make is remember that as soon as you wake your patient up, because I fully agree with Claude, your skin impedance changes. The temperature of your peripheries rapidly changes as soon as you're woken up from anesthesia. And so you can't accurately compare the train of 4 in the awake state immediately post-operatively with that recorded per-operatively, certainly from a research point of view. So things are changing very rapidly at that point in time.
Thank you very much. We have some questions left. Is EMG the best way to explore NM blockade level? One of the problems is due to changes in body conductance during heavy surgery, with massive bleeding, large volume replacements with crystalloid hypothermia, and the inability to come back to pre-anesthesia level and calibration. Who wants to answer to that question?
I agree. That's very complicated in such a patient, but all other techniques have at least the same problem. But in addition to all these problems, yes, the mechanic issues again has to be added. The impedance is very important for the stimulation electrodes. What we typically do, we make a supramaximal stimulation. It's about 20% over the maximum stimulus in order to avoid such changes. If you are at an end of such a period, what we sometimes do is we manually further increase the stimulation current. But almost never there is an effect of that. It's more relevant if you have a patient with a neurologic disease that you manually manipulate the stimulation current. And even more important, if a patient is cold, if a patient has unstable hemodynamic conditions, if a patient has long surgery, then it's very likely that this patient comes to the PACU with the tube and has to be rewarmed, has to be hemodynamically stabilized, and then the neuromuscular monitoring also works well. So I think, it's more theoretical problem.
Okay.
You can see it in diabetic patients as well. When I say diabetic, I mean seriously ill diabetic patients, where they have peripheral neuritis and the monitoring is not as accurate. So even when they're not bleeding heavily, diabetic patients can be difficult to monitor accurately.
But that's a stimulation issue, not a measurement issue. So then you have to change the stimulation technique. You can prolong the stimulation and you can increase from 200 to 300 milliseconds and the current. But this,
One small comment, never forget the huge improvement on the quality of the nerve stimulators and the continuous impedance of this new monitor. So we can get rid of more of the problems.
So thank you very much. Time is running and we are coming to the end of a very important and fruitful scientific session. And following your lectures and this inspiring panel discussion, I have extracted some take-home messages. And I hope you will agree.
We'll see.
So first of all, I learned post-operative residual neuromuscular block is more common than appreciated. Indeed. And there's increasing evidence that it is related to post-operative pulmonary complications.
Correct.
And to minimize or avoid the risk of a residual block, quantitative neuromuscular monitoring is highly recommended. And as you stated, EMG has been proven to be most reliable technique as of today. And with the guidance of such a good monitoring, the use of reversal agents can help to rapidly achieve complete recovery. And already after the first lecture, we learned that international guidelines are required to ensure a change in clinical practice and maybe to boost it and to use it.
Indeed, I agree.
I agree.
So,
Completely agree.
I see no dissent.
No.
And then we hope that our today's scientific show will contribute to a certain change of mindset in clinical practice. And I would like to thank, first of all, our experts in the studio for their time and for their inspiring lectures. And of course, the audience all over the world for your contributions and to our panel discussion and for your interest. And last not least, to GE, whose partnership made this medical education possible. So I wish you a very nice evening from Paris. Goodbye and take care.
Bonsoir.
Bye-bye.
Bye-bye.